is start.
Okay, all right. So we just had a wonderful talk from Dr. Umul regarding the pre-hospital care role in hyperacute stroke, its activations, the epidemiology, the importance, and the future of PHC, which is the mobile stroke units. So next, we would like to invite our next speaker. He is a interventional radiologist, Dr. Mohamad Syafeeq. He's an interventional radiologist in UPM. He's a clinical interventional radiologist, got his master's in medicine of radiology from UPM. And the striking thing is he's got a lot of interest in research and publications, multiple different research and publications in interventional radiology with over hundreds of citations, very impressive H index, I index. We would like to welcome our next speaker, Dr. Mohamad Syafeeq. Please welcome.
Okay, can everyone hear me?
Yes, we can hear you.
Okay, good. Thank you, Dr. Gurjit. Might I share my screen first? Okay, can you all see my screen?
Yes, we can.
Okay,
yes,
good. Firstly, I would like to thank the organizers, the Neuroemergency SIG group, for inviting me to give this talk this morning. I'm Syafeeq. I'm one of the radiologists, and I'm currently an interventional neuroradiology fellow in UPM Teaching Hospital. And I'm also currently the Deputy Treasurer for the Malaysian Neurointervention Society. Okay, so the talk this morning is going to be a very simple talk, not much of slides like Dr. Umul. Interesting talk from Dr. Umul just now. So we will start our talk, yeah? So I have got no conflicts of interest and no financial interest to disclose regarding this talk. So the first thing is, for those of you who are not familiar with the specialty interventional radiology. So what is interventional radiology? So this is taken from the Royal College of Radiologists website from the UK. So basically what it's trying to say here is interventional radiology is a specialty that deals with minimally invasive image-guided medical treatment. So what we do spans from the head to toe. So in the context of this talk, it's mostly got to do with acute stroke. So we come into the picture when traditionally we come into the picture when a procedure is planned. In the context of acute stroke, is mechanical thrombectomy plus minus acute stenting. Okay. So the keyword that you have to remember is when we talk about IR, it's minimally invasive image-guided medical treatments. So a bit of an introduction for our team. So UPM Hospital is relatively new. We started our acute stroke services somewhere when COVID started. So it was around April 2020. So our team is just one piece of the puzzle of the teams managing acute stroke patients. So as Dr. Umul mentioned, the pre-hospital care people are the first liners usually. And when they come to our emergency unit, what we have here in UPM is what we call rescue. Rescue is basically a network of teams managing acute stroke. So it's comprised of people from the emergency department, people from neurology, people from radiology, and people from the anesthesia department. And we also have a visiting neurosurgeon that assists us in cases where neurosurgical intervention is needed. So our team is comprised of 2 consultants, Prof. Sobri and also Prof. Ezamin. Myself is one of the fellows, and I have 3 other fellows, Dr. Fandi, Naim, and also Dr. Anas. And we have our huge group of supporting staff. what we call assistant interventionists. So these are people, the assistant medical officers, the nurses, and the radiographers. So this is the team, this is a group of people that we call assistant interventionists. So these people basically our backbone. So if we don't have them around, it's a bit hard for us to do our job. Okay. This slide is just to demonstrate the part of what we do in HPUPM. So as you can see, there are cases where we don't need that much of people, but there are also cases where we need more than 2 or 3 people. So this is just a collage of our team members performing mostly acute stroke procedures, but there are also cases where we do joint cases with other disciplines. Okay, so the essence of the talk. What is the role of an IR in hyperacute stroke? So traditionally, an IR comes into the picture when an endovascular thrombectomy is planned. And in some centers, they may also be involved during the acute stroke imaging. But we do things slightly different in UPM, where we are not just limited to the procedure and also to the acute stroke imaging. We also are involved in the pre, intra, and also post operative care. So the role of an IR is so much more than just the procedure and also imaging. Okay. So in our center, what we do is sometimes we are the ones receiving the referrals directly from the primary teams. So we've gotten referrals from physicians or emergency physicians from private centers. We've also gotten referrals from physicians from the government hospitals, whether it's in the southern states or whether it's in the northern states. And we've also gotten referrals from Sabah. So apart from our colleagues from emergency medicine and also neurology, we are also the ones receiving referrals directly from the referring teams. And during the imaging, we are there usually physically to plan the sequence. What we do here in UPM is slightly different. We use a MRI first policy for our acute stroke patients. So normally when we talk about MRI, there are certain sequences involved. So we'll talk about that later. But basically what I'm trying to tell you is that the sequences are dynamic, meaning there's no certain, there's no certain arrangement to what sequences come first. It all comes down to what we see during the initial imaging, and we plan the following sequences afterwards. So in our acute stroke protocol, the sequences are dynamic. It moves about, and it does not necessarily have to be complete. So meaning if you do a traditional MRI, maybe you end up doing maybe 6 or 7 sequences. We can just make do with maybe 2 sequences before we do further intervention. So traditionally, as I've mentioned just now, what we also do is procedures in the context of acute stroke is endovascular thrombectomy. Sometimes when patients require acute stenting, we also do acute stenting. And there have been instances where sometimes we are the first so-called specialist level to arrive attending the acute stroke patient. Along with the emergency and also neurology MOs, we decide on the administration of IV thrombolysis, but of course after discussion with our neurology colleagues. And post-procedure, we normally do follow-ups, meaning we do ward rounds, and we also plan the repeat and follow-up imaging. And when treatment is planned or where complications arise, we are also involved in the MDT discussions with the other managing teams and also the family members, and also conferences. And when we want to decide whether we would like to do say stenting, or the patient is best left with best medical therapy. And we have our own clinic, our clinic, where we accept referrals directly, and patients can walk into our clinic and request appointments. And these are in the context of acute stroke, especially for those planned for further procedures after the acute episode. So sometimes when patients come with an acute stroke, there's a clot and we manage to take out the clot. Patient undergoes rehab and recovery, but there is some stenosis, maybe an ICA stenosis. So what we do is we follow up with imaging, we follow up in our clinic, and then we discuss with the patient and family regarding stenting of the stenotic vessel that might have been the cause for the stroke in the first place. So in cases where there's an artery to artery embolism, so that is where we come into the picture. Okay, so to the next slide. So just to give the audience an overview of our stroke protocol. So this is our stroke protocol, our very own Putra acute stroke MRI protocol. So as you can see, this was published last year in our very own Journal of Cardiovascular, Neurovascular and Stroke. The first two sequences, DWI and FLAIR, if you can look at the acquisition time, meaning the scanning time, it takes less than 5 minutes. We have been familiar with what bleed looks like on DWI. So normally on the first sequence, DWI ADC, we are able to see whether this patient has got an acute stroke because of a bleed or because of an infarction. So after the DWI ADC scanning is finished, usually it's followed up by FLAIR. And when there is evidence of DWI FLAIR mismatch, the scanning is stopped temporarily for IV thrombolysis to be administered, and then the scanning is continued. So when we see evidence of large vessel occlusion or medium vessel occlusion, meaning M2 segment, so then we are already anticipating cerebral angiogram KIV thrombectomy on the MRI itself. So that is when we go to the family and discuss options to do cerebral angiography and also KIV endovascular thrombectomy, KIV stenting. So we don't really need to finish off all the sequences to then proceed to angiogram. Sometimes we stop at MRA or SWE to then push the patient to the angiography suite. Sometimes we stop at MRA because normally what we do before we start the angiogram, we do what we call a CT, expert CT. Expert CT is basically something like your normal traditional CT, but it's done in the angiography suite. So if there is any evidence of bleeding, whether it's because of the stroke itself or whether it's due to the IV thrombolysis, then we would likely stop and not do the cerebral angiogram KIV thrombectomy if there is evidence of bleeding on the expert CT that is done in the angiography suite. Okay. So to make things a bit more interesting, let's look at some cases. I've prepared 2 cases. So hopefully it's of benefit to the audience. So the first case, 71-year-old lady with hypertension and dyslipidemia. She presented with right-sided body weakness and vomiting, and at the point of presentation, she was already 5 hours into symptom onset. So what do we do in this case? So as you can see, I've put 3 pictures, the DWI image, ADC image, and also the FLAIR image. At the time, as if you can look at the white arrow, the left hemipontine region, there's hyperintensity. And on the PET ADC image, there's corresponding hypointensity. And it was decided at that time there was DWI FLAIR mismatch. And the patient presented to us at 5 hours of symptom onset. So it was concluded as an acute left hemipontine infarct with DWI FLAIR mismatch. IV thrombolysis was given after the FLAIR sequence with IV tenecteplase. The initial NIHSS score at presentation was 10. it was 5 at discharge, and at 3 months follow-up, it was 3. No bleeding was observed on the 24 hours repeat CT. So this is the so-called beauty of doing MRI for acute stroke. So it's quite well known that it's a bit hard to detect strokes, especially small strokes at the posterior fossa on CT. So we've come to realize that a lot of the small strokes that happen at the posterior circulation can be detected on acute stroke MRI, and that is why we believe in MRI as first line in acute stroke imaging. Okay, going to the next case. So this is just an image, a representation of what usually happens when an acute stroke comes to our center. So whatever I'm telling here is basically what I experience in our center. So the experience in other centers might be different. So what happens when the patient comes to us is the rescue team, our emergency physician, our neurologist, and also our radiologists will also attend the patient, including our staff. And MRI scanning is stopped in between. If a decision is made to administer IV thrombolysis, MRI scanning is stopped temporarily. And it's not necessary for us to complete the whole protocol. And as I've said, sometimes we stop at 2 or 3 sequences, and then we push the patient directly to the angiography suite for endovascular thrombectomy, KIV stenting. So case number 2, this is a case that I personally attended maybe 2 or 3 weeks back. You can see there's a DWI image, ADC, and also flare. This was a 67-year-old lady with metabolic syndrome who presented with left-sided body weakness with facial asymmetry, giddiness, and also headache. She was found to be aphasic. She had partial gaze palsy. She had ataxia and neglect. The NIHSS score total was 15 at presentation, and she was already 7 hours into onset at the time. So I decided at the time, as you can see here on the DWI image, the area of hyperintensity at the right parietal lobe. Seeing this pattern, I was already suspecting a possible large vessel occlusion with corresponding hyperintensity on ADC and also hyperintensity on flare. And true enough, if you can see here on the flare image in the white circle, you can see that the vessel, the M1 segment, and also part of the M2 segment of the right MCA is white. This is what we call a flare hyperintense vessel sign, meaning there is some blockage in the M1 segment of the right MCA. And on the SWE image, if you can see here, patient was moving slightly, but it can still be appreciated that there is some blooming, or the vessel appears more blackish as compared to the other side. So this is likely where the clot is situated in the M1 segment. And this is called a susceptibility vessel sign on SWE. And MRA just confirms the suspicion. So there's a cutoff of the right MCA, M1 segment on the MRA. So we did not thrombolize this patient. And we straight away pushed this patient into the angiography suite for endovascular thrombectomy. So what happened? So as you can see, the image that I'm circling right now, where the red arrow is, there's cut off of the M1 segment of the right MCA. And this was post mechanical thrombectomy. You can see that there is restoration of blood flow from the previously blocked M1 segment distally. I don't know whether you can appreciate this. Within the circle, there's the tip of the suction catheter. So we used a suction catheter in this case. And if you can appreciate this, the catheter is seen here, following my arrow into the ICA and then goes into the intracranial ICA and towards the MCA. This is an image that we do routinely in our center. This is an intra-arterial vasosity, which nicely demonstrates the ICA going to the MCA. And as you can see, these are the LSAs, the lenticulostriate arteries that supply the basal ganglia, which are seen nicely over here. and the M1 segment that goes to the M2 segment and so on. And you can see all these small perforators nicely supplying the infarcted brain area. So next slide. Okay, so this was basically what happened in this case. Sorry for the image. So this was about 1 a.m. in the morning. So this was the clot that we managed to aspirate out from the M1 segment. So it looks quite small here, but this is considered quite a huge clot blocking the M1 segment of the MCA. Okay, so what happened in this case, she presented with a NIHSS of 15, day 1 post-thrombectomy, NIHSS reduced to 7, and day 2 it reduced to 5. So in this case, we had a successful mechanical thrombectomy with TG3 revascularization of the blocked vessels. So apart from being involved in the acute stroke imaging and also the procedure, we also regularly follow up our patients. Of course, we manage these patients jointly with our colleagues from neurology and also anesthesia and ICU. So these are just some images of patients that we go and do rounds. As you can see here, it's quite common for us to bring maybe an iPad to show the patients the images when they first came, and also what happened after the thrombectomy or stenting if it's done. And you can see some of the patients are quite happy with the results. We also do have clinics. We have physical clinics and also online clinics. So one of my colleagues here, Dr. Fandi, is consulting a patient online. We have also had online discussions with patients from around the country, but also with patients who are outside of the country. So we've had discussions with a team of doctors from countries like Indonesia, like Singapore. Some of the family members of affected patients are doctors from Australia. So we've had discussions from teams in Australia. We've had discussions recently from with a patient who requested to consult the family doctor from Taiwan. So we do also regularly do discussions with outside or foreign patients. We also have physical clinics. So as you can see from the images here, we do discussions with patients and family members physically. This is in our recovery area. Okay, and we also have discussions with other disciplines with a patient in the wards, and also in the angiography suite. So conclusions, the role of an interventional radiologist in hyperacute stroke management is quite wide, and it's not just limited to plumbing work or just imaging. When it comes to acute stroke imaging, the planning of the imaging sequence, decision making, whether the patient qualifies for an IV thrombolysis, and whether to stop the imaging, we are largely involved also. We plan the follow-up imaging. Usually what happens with our stroke patients, when they have an initial MRI, successful revascularization is achieved, we usually plan a surveillance MRI, usually within 1 week of the first MRI, to see the resolution of the blockage, and also to see the final infarct core volume. And also when complications arise, we also do the imaging. Some of these patients, they might have concurrent issues. So when an acute stroke patients, they come, they routinely have a chest radiograph. Sometimes, occasionally, what we see on the chest radiograph is maybe an asymptomatic aneurysm or chest lesions, whether it's an infection or it's a mass. So we also arrange the CTs for these patients, and also do the necessary. What we also do are ward visits, follow-up of patients during admission, and also as outpatients. We have regular discussions with teams, other teams, and also family members, as well as conferences. We have clinic and many more. So before I end my talk, for those of you who are interested in acute stroke management, so we have an upcoming workshop early October in Johor. So we have limited seats for hands-on training, but we do have a masterclass for neurovascular and stroke, which you can join. I'll share this flyer with the organizers later. And just an overview of our society. We are quite a new society, but we have currently about 30 plus active members. But you are also welcome to join. Okay. Thank you. I suppose we can, questions. Yep.
Okay, thank you very much, Dr. Syafeeq. So again, if you have any questions, you can drop it in the chat box, or we can open the questions later. So I just like to say that it was a real eye opener, and wonderful to see such diversity. I was one of the people who initially thought that the initial definition is what IR would be. Just via image guided and a minimally invasive procedure. But it's wonderful to see that there is a team that sees the patient in the ED, the rescue team, a multidisciplinary team involving multiple levels, AMOs, nurses, radiologists, and different departments all coming together, from seeing the patient initially even getting the referrals to doing the procedure, and finally the follow-up and the telemedicine. It's just wonderful to see. A bit jealous actually that we don't have it. We don't have it in Selayang. But anyway, we like to open the floor to any questions. Before that, I would just like to start off. I would just like to clarify. Do you do MRI for every stroke presentations, or only in selected cases?
Okay, so I suppose it's sort of like a blessing also, because being a new hospital, we get to set the ground rules. So in our center, any patient that is suspected of having stroke symptoms, whether it's so-called a mild stroke, or like you said just now, whether it's a stroke mimic or whether it's a stroke chameleon, is sometimes I understand it's a bit hard to differentiate whether this patient actually has a real stroke, or whether it's just a stroke mimic or a stroke chameleon. So all patients that come to our center with stroke symptoms get an MRI. The only difference is whether this patient gets an MRI, meaning there and then, meaning when the patient comes, assessment is done, and then MRI is done straight away, or whether the patient comes, assessment is done, but then MRI is also done on the same day, but maybe slightly later after we have completed some of our elective MRIs. So we have a system where we code these patients. Code red, code yellow, and also code green. Code red meaning those patients who present within window for thrombolysis, which is taken as traditionally 4.5 hours, but according to wake up trial or extend trial, it can go up to 9 hours. So it depends whether the patient comes slightly early. If it's 4.5 hours or maybe slightly later than that, we have MRI to tell whether there is evidence of DWI flare mismatch. Where there is evidence of DWI flare mismatch, whether it's more than 4.5 hours, we still do give IV thrombolysis. That is after consensus discussion with the neurology and also our side. When it's slightly later, meaning if the patient has come to us maybe at 10 hours, there is already suspicion, or not to say suspicion, there's already anticipation that there is no DWI flare mismatch. If the patient is imaged on MRI, then the MRI can wait slightly longer. Not to say longer, but maybe at the time we have one patient that is scanned for an elective MRI. So maybe the scanning of this patient is done afterwards. So code green meaning So basically, code red is any patient that is eligible for IV thrombolysis. Code yellow means a patient that is not eligible for IV thrombolysis but might still be eligible for thrombectomy, which the window, as we know, is 24 hours. Code green meaning anything that is more than 24 hours. So the onset of symptoms to the presentation is already more than 24 hours. So the likelihood of us doing something acutely is much less. So code green. So code green patients will also get MRI on the same day, but they have to wait a bit. But essentially, all patients coming to our center with acute stroke symptoms will have an MRI. We also have had patients who come to us initially thought of having an acute stroke, ending up to have a stroke mimic. We've also had patients with pseudo strokes, meaning these are the category of patients who sort of they make up their symptoms, but in actual fact, they don't really have all these neurological deficits. We've also had patients who presented with strokes and ending up to have things like tumors or bleeds or other things that mimics a stroke. But essentially, what I'm trying to say is all patients who come to our center will have an MRI. It's just a matter of when the MRI is done, whether the MRI cuts the queue of patients with elective MRIs, or whether the MRI is done maybe slightly later than the scheduled MRI patients, or maybe when we finished our MRI list for the day, meaning maybe it's finished at 4 something or 5 something, then the code green patient comes in to have the stroke MRI done. So essentially all patients have an MRI done.
Right, that's it's fantastic, wonderful to hear. I think the next question would be for both, maybe Dr. Umul and Dr. Syafeeq both.
Yes.
So we know that the endovascular therapy is still very limited in our country. It's limited by a distance from endovascular stroke centers, limitations of these endovascular stroke centers itself. I think what is your opinion on this? Is there any role for networking between hospitals and endovascular stroke centers? And what about maybe Dr. Umul can highlight on ambulance diversion to these endovascular stroke centers because of its limitation in our country? Maybe Dr. Umul, you can give your opinion on this ambulance diversion to endovascular stroke centers first, and then maybe Dr. Syafeeq, you can enlighten us. Maybe is there any networking between other agencies and in your center?
Okay, thank you, Dr. Gujit. So bypass ambulance or diversions of an ambulance to the stroke center. So actually we implement the bypass quite sometimes because in Sungai Buloh, when the patients, when our responder go to response and then they thought or suspect stroke patients. So they call for medical directions from medical director or in MACC. So actually they will divert the ambulance to UITM. Yeah. So in HKL because we have as a stroke center as well. So that's why the early notification or pre-notification. So we do it since a few years back, meaning from the PHC, so they alert the MACC, okay, this is acute stroke. So MACC will alert the MO or specialist in resus 2 to alert the neuro team for the acute stroke. That's why since last year, so the care is not divert by bypass the case bypass zone. So instead of patients go to the zone and being examined by neurologists, so they send the patient from the triage. Okay, they fill up the forms and then bypass the zones, go to the CT scan. So neurologists wait for the patient in the CT scan. Okay, so I believe the other state as well, when they don't have a stroke center, we call them.
Okay, all right. Okay, thank you. Your opinion, Dr. Syafeeq, is there any networking done between centers that have these stroke facilities, EVT facilities especially, and other centers?
Okay, thank you, Dr. Gurjit. So I believe some of the people in our audience are already in our network. I think Dr. Nasrina and some of our colleagues in nearby hospitals such as Serdang or Kajang are already in the so-called. What we have is a WhatsApp group of networking of hospitals surrounding UPM Hospital. So what happens is usually they will post referrals, and everything is done accordingly after the referral is posted. We've had cases of ambulance diversion before. Most recently, we have had one ambulance diversion maybe a few days back. It was a stroke patient who initially was supposed to go to Hospital Kajang, but then the diversion was made to come to UPM instead. So networking is quite important, because we do know in terms of limitation of facilities and also expertise, not all or not many centers have endovascular thrombectomy services available. So that is why we normally say, if you don't have endovascular thrombectomy services, you are welcome to come to our center or refer cases to our center. In terms of endovascular thrombectomy services being available, I do know that at least in our center, we provide the service 24/7, meaning if the referral comes at 3 o'clock in the morning, the team will have to come in also at 3 o'clock in the morning. But I also do know of centers that have so-called a time limit of referral, meaning after certain hours, if a stroke patient comes and is eligible for thrombectomy, then it's not possible to be done at that center, and the patient might have to be diverted to other centers that have 24 hours services available. So in terms of making the service more widespread, I suppose, number one, it has to be manpower. Number two, I think Dr. Nasrina also mentioned just now, in terms of costing. At the moment, unfortunately, we do not have any support in terms of budget, because the deposit that we usually ask is usually purely for the device. And normally it doesn't really go up to that amount, but sometimes it does go to that amount depending on case. We do have certain cases where patients cannot afford the treatment, and sort of payment plan is done with the finance unit. So for instance, we've had quite a few cases where is entirely not possible for the patient or the family to put any sort of payment. We've had to call some of the NGOs to help out these patients and sponsor the cost of the device. We've also had patients where, of course, if it's 3 o'clock in the morning, no one has 20K available on the spot. So what they do is they usually pay some amount first after discussion with the finance people, and then we proceed with the procedure, and the rest of the payment is done for the device is done afterwards, meaning whether it's after discharge or whichever system that is possible for the finance unit. So in terms of making the services more widespread, networking, as Dr. Gurjit said, and Dr. Umul said, is very important. Communication between centers is important, and also maybe in terms of human resource, and in terms of financial support for these patients who require thrombectomy services. So because the device is not cheap, it can go to as cheap as, maybe for an aspiration catheter, it would maybe take 4 or 5K per catheter. If some other devices are needed, then it can go up to 15, 16, 20, 25. If a stent is needed, acute stenting is needed, then maybe another 10 to 15K just for the stand. So it's not cheap. So it's important for all parties, not just the doctors, but also the administration, the policymakers to help out to provide the service.
Right. Thank you so much for that. So we open the floor. Anybody has any questions?
Dr. Syafeeq, Nasrina here.
Hello.
Yeah, hi. I would like to ask two questions.
Yep.
What is actually ADC sequence? Yeah.
Okay. ADC stands for apparent diffusion coefficient. It's usually a sequence that is paired with DWI. DWI is diffusion weighted imaging. So depending on what we see on the paired DWI ADC, then we call something as maybe an acute stroke or a subacute stroke, or whether it's not an acute.
Syafeeq terkeluar ke ni
I think we have lost him. Wait, let me just
Yeah.
contact him and see.
Yeah, can. Okay.
Okay, I've just contacted him. Let's just give him a minute or two to just
Thanks.
join back.
Sure.
Hello.
Okay.
Okay, sorry. It's
Okay.
a bit of a connection problem. Okay, so when
Dr. Syafeeq, we can't really hear you there.
What you see is hyper intensity on the DWIC. Some papers are now looking at the ADC to look at whether. Yep. Hello.
Yeah. I think just now
Can
you
you
were
hear me?
breaking.
Okay. Can you hear me clearly now?
Yes.
Okay, good. So some papers are now looking at the value of the ADC to prognosticate whether some of these lesions are, how to say, whether some of these lesions are eligible for acute stroke intervention, or whether it's best to not intervene during the acute stroke episode. So it's a bit complicated for me to explain in one session, but basically that's it.
Oh, okay. So you use ADC is also part of the assessment of all the patient, or only for certain patient?
Normally we look at when patients come to us, or whether if the patient has had an MRI in other centers which refer to us, we look at the appearance of the ADC. We can sort of tell whether this stroke is, number one, whether it's been quite long, meaning from the time of onset to the time of referral, it's already lapsed more than 4.5 hours or more than 9 hours. And also on the appearance of the ADC, we can sort of tell whether the collateralization, meaning the collateral status of the patient, is whether it's good or it's not so good. So if the collateral status is not so good, then that tips the scale to not intervening more than intervening.
Oh, okay.
Yep.
All right. Okay, my second question would be, when do you do suction only, or when do you stand the patient?
Okay. Normally, traditionally speaking, we try to start with suction because, of course, because it's cheaper. But nowadays there are devices where the setup is suction with a suction device, meaning there's a so-called like a vacuum that assists in suction. So that might be slightly more costly. We do suction normally for clots that we anticipate might be easily suctioned out. When we anticipate things like intracranial atherosclerotic disease, meaning ICAT, where we see on our sequence, we have vessel wall imaging sequence where we can sort of anticipate the presence of intracranial plaque. Then in those cases, we anticipate the use of a stent. So in those cases, we normally try to do suction or aspiration first. If it's not successful after the first or second pass, we will then proceed with a stent retriever, normally something that is detachable, meaning the stent that we put in to sort of take out the clot. We try to take out the clot and we try to open up the stent and see the flow distal to the occluded segment. So if there is evidence of intracranial atherosclerotic disease or ICAT, which means that we might have to consider acute stenting, then we detach the stent and leave it there where the stenotic or the plaque area is that's causing the occlusion. Sometimes the occlusion is not really because of a clot. It's probably more of an inflammation of the ICAT plaque that causes the vessel to close off. So of course on MRI we only see this as an occlusion, but on the angiogram we will be able to tell more whether this is an occlusion because of an embolus or thrombus, or whether this is because of an ICAT per se.
Okay, so
Yep.
the 20,000 that we normally inform the patient,
Yep.
there is a range to that, correct?
Yeah, so meaning 20,000 is the maximum amount. Normally we don't really end up with 20,000, but we cannot tell that beforehand.
Okay.
Yeah, because if we tell someone, let's say if you want to purchase a car, we tell you the price is let's say 50,000, and then when you sign the agreement, it's actually 100,000. So it's not so easy. Yeah.
Okay.
Yeah.
Okay, all right. So the third question would be, you mentioned just now, if the patient is eligible for thrombolysis, you will stop
Yep.
until the second sequence and you proceed with the thrombolysis first, right?
Yep.
So if there is an evidence of this patient having large vessel occlusion, of course, we will still start with thrombolysis. How, so it will be altiplase, is it? Or start using metalase?
Depending on which agent is available. So from our personal experience, we actually quite prefer tenecteplase, TNK. But of course, if TNK is not available, then we use altiplase.
Okay, so concomitantly, patient will be transferred to angiosuit, and you guys will straight away do the angiogram and start with the procedure.
Yep.
Oh,
So normally it's we will try to finish off the sequence if number one, patient is cooperating. Number two, if it takes time for the family member to decide whether to allow us to proceed with thrombectomy because of the issues, because we have to discuss beforehand with the patients and not with the patient, with the family members, the pros and cons of doing a mechanical thrombectomy, the possible complications, what we have to anticipate post-procedure, and also the cost.
Alright.
So yeah, it takes time for the family members. Sometimes family members, they need to discuss with other family members in terms of gathering the cost, and also signing the consent forms and whatnot. So during that time, we try to finish off the MRI sequence, because finishing off the sequence helps us in terms of anticipating what might happen afterwards. So we've had some imaging markers on MRI that we are currently looking at that sort of anticipates whether this patient, after given reperfusion therapy, whether it's just IV thrombolysis or IV thrombolysis and thrombectomy, or or thrombectomy only, whether these patients likely will have an intracranial bleed afterwards, and this can be anticipated from the MRI that is done initially.
Okay, I
Yeah.
see. Oh.
So the info from the MRI is important also. It's not just about plumbing work, but it's also about anticipating and also risk stratification.
Okay. Okay, very interesting.
Yep. If you can come, because we've had just last week we've had one physician from Hospital Putra, if you know Dr. Gayatri.
Yeah.
Yeah, she came to us for an attachment, but only for 1 week. So, but she scrubbed in during one of the cases at midnight with my colleague. So she got a sort of a feel of what we normally do when acute stroke patients come to our center. So if it's possible, if you want to have an attachment or something in our center, we will. I mean, our team will welcome you.
Okay.
Yep.
She was there for what? Is it for the preparation for?
And she was just coming to see what's happening, just getting a feel. Yeah.
Okay.
But it's 1 week, so if it's 1 week, it's there's not much that we can show you.
Okay, all right.
Yep.
Understood. Okay, because I think our medical colleague is not in the WhatsApp group. Sangat.
Yeah.
All right. Thank you so much.
No problem.
Any last questions from anybody? We open the floor again.
Hi, Dr. Syafeeq. Chow here.
Hi, Dr. Chow. Hi.
Thank you for the excellent presentation. Just one quick question.
Yep.
Any reason why you prefer tenecteplase rather than alteplase? Thank you.
Okay. Number one, because of the simplicity with which it's administered, because tenecteplase is a single bolus administration, as compared to alteplase, where there is an initial bolus followed by the the titrated administration afterwards. Number two, we notice that our patients with tenecteplase, they tend to have a higher percentage of recanalization even before thrombectomy, meaning these patients, when they are given tenecteplase, when there is evidence of large vessel or medium vessel occlusion, when we push to the angiography suite, we do the angiogram, we just end up doing an angiogram, meaning everything has recanalized, which is different compared to alteplase, where there is, I don't have the numbers, but we see less people given alteplase with spontaneous recanalization, not to say spontaneous, but recanalization after IV thrombolysis is seen much less compared to alteplase, compared to tenecteplase. So the simplicity of the administration of the medication, also the rate of recanalization post thrombolysis is seen much more in tenecteplase as compared to alteplase, and we've seen that patients given tenecteplase, they have bleeding complications much less as compared to patients given alteplase.
Okay, thank you, Dr. Syafeeq.
Yep.
Any other questions from the floor?
Yeah, related to that kan, maybe this one for Dr. Umul, in abroad countries, do they use tenecteplase ke ataupun they use alteplase for the mobile stroke unit?
They only stated RTPA. I don't know whether this. I have no idea whether this what type of the RTPA. RTPA. So if in Thailand they use alteplase.
Actually the so-called the recommended, or it's still within the guideline at the moment, is alteplase. But trials have started coming out where some centers actually compare the usage of tenecteplase compared to alteplase, and encouraging papers are coming out to sort of support usage of tenecteplase as compared to alteplase. But of course, it's not in the guidelines yet.
So that's why in the US as well, they use alteplase.
Yep.
US.
Guidelines, yes, alteplase, but off-label, meaning something that is not formally put in the guideline. People are starting to realize that tenecteplase is superior compared to alteplase. But of course, whatever I'm trying to tell you is based on our center's experience and also some of the preliminary papers that have come out so far.
Thank you, thank you.
Okay, and, any other questions? Okay, I think if there are no questions, then we'd like to wrap up today's Neuro EM CME class. Thank you so much to the speakers. We've got good information ranging from pre-hospital care or until the endovascular therapy and up till the follow-up disposition and looking for the way into the future to improve stroke care, improve its mortality, morbidities, and improving our community level health as well. So with that, I would like to thank you very much, everybody who has participated. Again, you can claim 2 CPD points by scanning the QR code. And we wish to see you again in the next CME. With that, thank you very much.